Hello everyone, welcome to the next module of the ETAT training course. My name is Mary Morgan, I'm the head of pediatrics in Pietermaritzburg and I'm going to be taking you through this module. Module 1 is triage. 1/3 of children under 5 years who die in hospital die within the first 24 hours. This is often for multiple reasons. However, one of the reasons is that sick children are not identified quickly enough. Triage is the solution to that problem. After this module, you should be able to define the term triage. Triage all sick children when they arrive at the healthcare center according to the following categories: those with emergency signs, those with priority signs, those who are non-urgent cases. You should be able to perform the triage process under 1 minute, initiate appropriate general management, and know the importance of reassessment of patients in the queue. Triage forms part of the name of the ETAT course, which stands for Emergency Triage Assessment and Treatment. We can see from its position that it is vitally important to the process. Triage is defined as the sorting of patients into priority groups according to their sickness, severity, and availability of resources. Triage must be quick and must look for life-threatening problems. It should be done on arrival at hospital before collecting the medical records so that valuable time is not wasted. Please note that you don't need to take the child's vital signs in order to conduct triage. In fact, we don't want you to take the vital signs for the triage process. If vital signs have been done, then they can be included in, as you will see in some of the assessments. However, we want this to be done quickly without wasting time, and therefore we do not want vital signs to be part of this process. The components of triage, or the categories that patients are sorted into, are emergency, priority, and queue patients. Emergency patients, which as you can see is marked in red, requires immediate emergency treatment. We need to take the child to the resuscitation unit and do the following: give them the appropriate emergency treatment for the sign that you've picked up, call for help from a senior doctor, and carry out emergency laboratory investigations. Priority patients need rapid assessment and attention, but because they don't have life-threatening problems at the moment, they must be moved to the front of the queue and be seen as soon as the next healthcare worker is available. It's important to explain what you're doing to the rest of the patients so that they don't get upset. They need to understand the reason the patients are being moved is because of their clinical condition and not for any other reason. Queue patients can wait their turn in the queue for general assessment and treatment. However, please remember, we need to keep on triaging those patients in the queue in case they deteriorate into emergency and priority signs. How do we decide if a child is an emergency? We look for the following signs: airway problems, breathing problems, circulation problems, coma or convulsion, and dehydration. In other words, we look for life-threatening problems. Priority patients are determined by the acronym 3TPR-MOBI. This consists of 3 T's, 3 P's, 3 R's, and MOBI. So, a tiny baby, a baby with a high temperature or low temperature, a patient with trauma or other urgent surgical conditions, patient with severe pallor who has been poisoned or has taken something, severe pain. 3 R's are mild or moderate respiratory distress. Remember, severe respiratory distress was an emergency sign. A patient who is restless or irritable or lethargic, or an urgent referral from another centre. MOBI looks for malnutrition, which is visible severe wasting, or edema of both feet, major burns, or impaired circulation. Non-urgent or acute patients are all the rest of the patients, but as we've said, they need frequent reassessment in case they deteriorate to become an emergency or a priority patient. Let's start then with the emergency signs, airway and breathing. Throughout this module, we refer to Chart 1, which is found on page 73 of your manual. This chart is the triage chart. It's divided into 3 columns: assess, action, and treatment. You'll note before we start assessing airway and breathing, or before we start managing airway and breathing, we need to check for head or neck trauma. We don't want to save the child's life, but leave them paralyzed. So we need to be careful to make sure that we don't move a damaged cervical spine. To assess airway and breathing, we need to know, is the child not breathing? Is the airway obstructed? Is the child blue? In other words, has central cyanosis or an oxygen saturation less than 90%? Or is the child in severe respiratory distress? If any of these signs are positive, we take the child to the resuscitation area. We would then manage the child according to whether or not we suspect a foreign body aspiration or not. This can be found on Chart 2, which is managing the airway, or Chart 3, which is managing a choking child. Moving on to circulation, this has 2 components. C1A is shock and C1B is cardiopulmonary arrest. For those of you familiar with ETAT in the past, we used to only assess shock. However, we have now introduced the cardiopulmonary arrest module. Chart 4 refers to the management of circulation. If a child has cold hands and their capillary refill time is 3 seconds or more, and they have a weak, fast pulse, then they would be taken to the resuscitation area. Note, in the case of circulation, unlike airway and breathing, all signs must be positive in order for us to classify them as an emergency. As you will see later, if only 1 or 2 of the signs are positive, that would then be classified as impaired circulation, and that is a priority sign. Once we take the child to the resuscitation area, we would stop any bleeding, give oxygen, make sure the child is warm, and insert an IV or intraosseous line and give a fluid bolus. It is important to check for severe malnutrition and treat accordingly. This will be seen on Chart 4. We need to check the glucose, and as we do not know whether or not this child may have a severe infection causing shock, we would commence antibiotics. In assessing for cardiopulmonary arrest, again, we need all signs to be positive. The child must not be breathing, have no pulse, or they have a pulse but it's not sustaining life. In other words, it's less than 60 beats per minute with poor circulation, and they have no signs of life. Sometimes it can be difficult to feel for a pulse, which is why we look for signs of life. If all those signs are positive, we immediately take to the resuscitation area. We call for help. We open the airway, again according to Chart 2. We give 5 rescue breaths and we start compressions. There's a different ratio for 1 rescuer versus 2 rescuers. And if we have an automated external defibrillator, we would attach that to the patient and follow the instructions. The next emergency sign that we assess for is coma and convulsion. Coma, which is classified as a P or U on the AVPU scale, or a patient who is convulsing currently. If either of these are present, we take to the resuscitation area, manage the airway, position the child, again making sure we don't have neck trauma, check the glucose and abort the seizure. To assess for coma, we need to know whether or not the child's level of consciousness is disturbed. A rapid assessment of a conscious level we do according to the AVPU scale. This is as opposed to the more complicated Glasgow Coma scale. The quick assessment of conscious level is A is for alert, V responds to voice, P responds to pain, or U is unresponsive. If the child only responds to pain or is unresponsive, this is a coma. If they respond to voice, then this will be classified as lethargic, and that is a priority sign. But for the emergency sign, we're looking for a patient who responds only to pain or is unresponsive. We then treat them as an emergency. Assessing for convulsions. Is the child convulsing now? Remember, we don't treat a child with a history of convulsion as an emergency patient, but only if they are convulsing now. Generalized convulsion is easy to detect. Many of us have seen those. But remember, in neonates and small children, the signs may be more subtle. Flickering eyes, deviated eyes, just twitching of the hand or foot, twitching of the mouth, repetitive movements, or apnea. If any of these are present, we treat as an emergency. The last of the emergency signs is dehydration. When assessing this, we first have to ask the caregiver, does the child have diarrhea or vomiting or poor feeding? If they don't have those, then we can move on to the priority signs. However, if they do have those, then we would then assess the child to see if they're lethargic. Remember, V on a AVPU scale, drinking poorly, sunken eyes, and a very slow skin pinch. We need 2 of those signs to be positive to classify the child as an emergency. We would take the child to the resuscitation area. We would attempt oral or nasogastric rehydration. If that is unsuccessful, we would give intravenous or interosseous fluids. We need to review the patient 2 hourly for shock and fluid overload, and review 4 hourly for hydration status. In all patients, we would also check the glucose. There may be other emergency medical or trauma-related conditions that might not be picked out by the ABCCCD approach, such as a bulging fontanelle, open fracture, etc. You're welcome to use your experience and judgment to decide the mode of treatment required. However, just remember, if we send too many patients at the same time to the emergency room, then we won't have time to treat them properly. So we need to make sure that we are treating patients who have life-threatening problems as emergencies. The general treatment is, so first of all, don't wait for the entire triage process to be completed. Take the child to the emergency room as soon as you pick up any of the emergency signs. So if the child passes the airway and breathing and you move on to circulation and you find that the child is in shock, don't go on to assess coma and convulsion and dehydration. That can be done in the resuscitation room. But take the child immediately to the resuscitation room so that you can start management immediately. Once you've started the management, you need to make sure you call for senior help, do emergency blood investigations, always check for neck or head injury, and consider the nutritional status of the patient. If there are no emergency signs, in other words, you've gone through airway, breathing, circulation, coma and convulsion, and dehydration, and found no signs that would make that patient an emergency, then we would move on to the priority signs. As mentioned, the priority signs fall under the acronym 3TPR, MOBI. We start looking for the priority signs by assessing the 3 T's. These stand for tiny baby, temperature, or severe trauma. Tiny baby, we would look for a baby that's less than 3 months of age, or if we don't have the age, less than 5 kilograms. These babies are extremely vulnerable, therefore we don't want them sitting in the queue for a long time, as they may become hungry or cold, and we also don't want them sitting next to children with other infections. So we move them to the front of the queue so that they can be assessed quickly and either admitted or sent home. A child with a high or low temperature would be classified as a priority patient, and a child with severe trauma or other urgent medical or surgical condition. The 3 P's stand for severe pallor, poisoning, or severe pain. To check for pallor, we don't have to check for a hemoglobin. However, we see it best of all in the child's palm. If we compare the child's palm with the caregiver's palm or the healthcare worker's palm, we can see whether the child appears very pale or even looking white, and this would indicate that the child is severely anemic. If there was a history of drug ingestion or coming into contact with another dangerous substances, this again would be treated as a priority, and a child in severe pain should also be moved to the front of the queue. Remember, while the child is sitting at the front of the queue, which may take up to an hour to be assessed, we would need to give them pain relief in the form of paracetamol. The 3 R's stand for restless respiratory distress or urgent referral. It's not only a restless patient, but a lethargic child or an irritable child. So again, V in the AVPU scale. A child who responds to voice but is drowsy and not really interested in what is going on around them. Or a child who is continuously irritable, crying, and inconsolable. Respiratory distress, again, we said this was not severe respiratory distress, but mild to moderate severely distress. You may need to use your judgment or experience to decide what should be done, whether to classify this as an emergency or a priority. An urgent referral, we need to make sure that we read the letter from the clinic or doctor carefully and make sure that it is an urgent referral. If it is an elective referral, then that patient can wait in the queue, but urgent referrals would need to go to the front of the queue. The last section is assessing for MOBI. Starting with malnutrition, this is severe wasting. This is seen best at the arms, legs, chest, and buttocks, where we look for loose skin. In addition, the head may appear big for the body due to severe wasting. Edema can also be a sign of malnutrition, especially if it is accompanied with hair and skin changes. In order to assess this, we need to look at the dorsum of both feet so that we can assess. Localized edema or edema of one foot might be indicative of injury or infection. So we need to look at both feet to look whether or not there is edema. If not severe acute malnutrition, this could be a sign of heart failure, kidney disease, or liver problems. We therefore need to treat these patients as priority patients by moving them to the front of the queue. A patient with severe burns would also be a priority patient. If this burn occurred within 3 hours, then it's worthwhile to cool the burnt area with running water for a minimum of 20 minutes while they're waiting at the front of the queue. This is to prevent ongoing damage from the burnt skin. Otherwise, we'd manage them according to the guideline. Impaired circulation, remember we discussed this under shock. This is present if there are 1 or 2 signs of shock. In other words, cold hands, prolonged capillary refill, or weak or fast pulse. If just 1 or 2, then this would be impaired circulation and not shock, and therefore we would treat the child as a priority patient. So the general treatment, as we've been saying, is to move the child to the front of the queue. This generally means that the child needs to be seen within half an hour to an hour. In very busy POPDs, some of the patients may sit there for several hours, so we need to make sure that these patients are taken to the front of the queue so that they can be seen as soon as possible. You can start some management while they're sitting at the front of the queue. For instance, if they have a temperature of above 38, you could give them some paracetamol. If they have diarrhea and have signs of impaired circulation, you could give them sips of oral rehydration. If there are no priority signs, the child may continue to sit in the queue. However, please note that they need to be frequently reassessed for changes in condition and then reclassified accordingly. So the steps one would take is assess airway and breathing. If they're positive, take them to the emergency room and treat. If negative, move on to C. Assess C. If positive, treat. If negative, proceed to D. Assess D. If positive, treat. If negative, proceed to priority signs. In summary, triage is the sorting of patients into priority groups according to their need. All children should undergo triage. The main steps are: look for emergency signs, then treat any that you find. Look for priority signs, place them at the front of the queue so that they can be seen within an hour. Move on to the next patient. Triage should be carried out quickly. You'll soon learn to observe several things at once. For example, when assessing the airway and breathing, you may note that the baby is very small or is restless. With practice, a complete triage, if there are no emergency treatment signs, can take less than a minute. Continually reassess all children in the queue. The next step is for you to complete the assessment questions, which will be found on page 10 and 11 of the manual. Thank you very much.